You are now listening to Nailed It, the Orthopaedic Surgery Podcast.
Alrighty. How's everyone doing? We're back at it again with some of the Spine Citations classics. I'm Sohum Patel, PGY3 at Indiana University, and I'm joined here today by Jose.
How you doing, everyone? It's Jose here, medical student at the American University of Integrated Science in Barbados.
So I'm sure by now you guys have become familiar with the Spine Citation Classic series. This is part one of a two-part series on spine infection. What we're going to do today is focus on infections of the native spine. So not going to discuss postoperative infection. So let's go ahead and jump into things. So just a brief background. So when we talk about infections in the spine, it's sort of a continuum, but a couple of terminology to be familiar with are words like discitis, which refers to infection of the soft intervertebral disc, sometimes referred to as spondylodiscitis. Vertebral osteomyelitis, which is an infection of the bone itself in your vertebral body, and then spinal epidural abscess, which can occur anywhere in the epidural space, ventrally, more common than dorsally. And this is a spectrum of disease, and these things often coexist. Unlike most forms of adult osteomyelitis, and I specify adult osteomyelitis, which occur from local spread. For example, in the diabetic foot, you have an open wound and an ulcer and the bone gets infected. Vertebral osteomyelitis starts, generally speaking, with hematogenic seeding. It can be post-procedural or come from contiguous spread from a psoas abscess, retropharyngeal abscess, something like that. And then, the biggest challenge with this entity of native spine infections is the difficulty in diagnosis. And obviously this represents a very potentially morbid condition if it were to progress and lead to neurologic compromise. So it's definitely something important to recognize, diagnose, and treat appropriately. So with that, we're going to run through some of the anatomy, pathophys, and management of native spine infections. So to start things off, this is a review article out of the AOS, Journal of American Academy of Orthopaedic Surgery, published in 2016 out of Nebraska. And these authors kind of run through top to bottom some of the definitions and treatment of native spine infections. So let's go ahead and get things started. So some of the things they mention obviously are presentation. The patient comes to your clinic or in the ER. How do you recognize a patient that has or is at risk for a native spine infection? So the triad that I keep in mind is, back or neck pain, fever and leukocytosis or elevated inflammatory markers. And there's a patient population that has it at a higher risk for spinal infections, and that's patients with diabetes mellitus, IV drug use, HIV, renal failure, cirrhosis, things that would cause an immunocompromised state. So, I briefly mentioned the different causes of spinal infection, but we're going to kind of focus on a hematogenious spread. So, we discussed the venous system, the Batson paravertebral plexus. It's a valveless venous system that allows retrograde flow back to the spine, and that's implicated in the spread of infection. There's not any solid evidence or literature on this, but it can lead to seeding from distant sites, bacterial endocarditis, things like that, and cause an infection to seed in the paradiscal region. So, we talk about the continuum of disease. So vertebral osteomyelitis is often the first place, is the end plates have a rich blood supply. And then this can spread to the avascular disc space and then culminated into an abscess. And this is most commonly in the lumbar spine, followed by thoracic and then in the cervical spine. And only about 20% of these patients are presenting with neurologic compromise. So like I said, the triad of back pain, fever, leukocytosis is generally the patients that you'd want to work up further. Focal tenderness is a specific physical exam finding. You'll find point tenderness. And that's why the H&P is kind of one of the most important things. You're looking for risk factors, recent sepsis, et cetera, in order to aid in the diagnosis. And then obviously lab work, ESR, CRP have been shown to be highly sensitive and specific. One of the things in the differential is also, tuberculosis spinal infection, which generally leads to granulomatous infection. So tuberculin skin testing is something that you should discuss in patients who are at high risk if they're incarcerated, if they've immigrated from endemic areas, things like that. So the most important thing, we talk about treatment. We're obviously orthopedic surgeons, but it's important to know that the mainstay of treatment for native spine infections except for certain cases, is medicinal with IV antibiotics. So it's important to get an organism. And this can be done either via blood cultures, CT guided biopsies or X-ray guided biopsies. And then in rare cases, surgical biopsies. So we try to hold antibiotics if we can to aid in our culture value, unless a patient is, in septic shock. Then we generally recommend holding antibiotics, getting blood cultures if those are positive, treating the organism, or trying to obtain a biopsy in a minimally invasive fashion in order to treat the offending organism. We mentioned a little bit here on imaging. X-ray findings for spinal infection are not present until the infection is significantly progressed. But you can see, end plate destruction, vertebral collapse, some sort of osteolysis, and even deformity to some degree, with end stage infection. But this is not until way later on in the disease process. MRI is definitely the modality of choice in early infection and localizing infection and determining, what anatomic structures are involved. You can evaluate the disc space, vertebral bodies, and the epidural space. There are other imaging modalities which are less frequently used. They have different bone scans and radio tracer studies. I'm not super familiar with those. We don't use them in my institution. So generally speaking, we're ordering MRIs with and without contrast to help evaluate the extent of infection and whether or not there's a presence of an abscess. And then there are obviously different surgical approaches, but the mainstay is obviously stabilization of anything that's been destabilized by infection and eradication of infection. So surgical decision-making is, pretty controversial. And some of the hard indications for surgery are obviously, neurologic compromise or progressing neurologic compromise, overwhelming sepsis, so surgical intervention to then reduce bioburden. And then lastly, if a patient has, refractory to disease. So kind of the important points that this article runs through is that, it says a pretty morbid condition if it's not diagnosed and recognized early. It requires a high index of suspicion because, so many people are presenting to emergency departments with back pain. But you do have to look out for patients with risk factors and order the appropriate imaging, determine the causative organism, and, start on the appropriate antimicrobial treatment, and then reserve surgery for specific cases. So this is a nice brief overview, and we'll jump into some more specific articles here. This is a diagram. I think, this is a little bit useful in kind of understanding the spectrum of disease. So this is referring to things that, would lead to epidural abscesses. And this could obviously come from direct spread from vertebral osteomyelitis, or can come from a distant source, endocarditis, or, local abscess along the psoas. So this is an article published in 2013 in the European Spine Journal. And this is by Dr. Duarte and Dr. Riccaro. This isn't, I chose this article because they have a good diagram and a good algorithm in working these patients up and how to appropriately triage, native spine infections. So running through some epidemiology, I know we already touched on some of this stuff. There's a bimodal distribution, which I think is important. Generally speaking, men in their 50s are the patients at highest risk. And then we talked about, the comorbid risk factors, diabetes mellitus, again, HIV, renal failure, and liver cirrhosis. We already discussed some of these different theories of pathogen spread. We're going to go ahead and jump forward to some of the treatment algorithms. So say you get a patient, and this is their diagnosis algorithm and kind of workup in these patients. So you get a clinical suspicion of a spinal infection. So again, you need a high degree of suspicion, non-specific back pain, fever, and then if they're having infections in the neck or around the cervical spine, they could have some sorts of dysphagia, torticollis, things like that. And then obviously red flag signs like neurologic weakness, numbness, incontinence. Those are often not present until way later on in the disease course. So you get suspicion from your patient based on their history, some imaging findings. You have an elevated ESR, CRP, blood cultures. And then you get your advanced imaging. So MRI, and if the MRI is positive, you can confirm your infection. And then this is when they order the radionuclide imaging is if the MRI is inconclusive. And if that's positive, then that will confirm the infection and that will make the diagnosis for them. So this is kind of their imaging algorithm. And then moving forward, so this is kind of the treatment algorithm and how they decide, who needs surgery and who can be treated with medical management. So like I mentioned, the major three things that we're looking for in somebody that would be treated with surgery right off the bat would be neurologic deficit, spine instability, sepsis, and then also, we talk about refractory cases that have failed medical management. So if they have any of those things, they get surgery. Obviously, cultures are taken at the time of surgery and they get targeted antibiotic therapy. If none of those three factors are present, CT-guided biopsy is performed, and hopefully a pathogen is identified that can target antibiotic therapy. And if a pathogen is not identified, then the patients then undergo surgery for a surgical biopsy. So, generally speaking, most of these patients are not making it to the point of requiring surgery and have good results with treatment with antibiotics. And that's kind of the point of this algorithm, I think. So their key principles of treatment are, antibiotic therapy to eradicate the infection, restore spinal structure and stability. Microbes love an unstable spine. And so if there's a progressive infection that has caused instability, it's important to stabilize that. And then obviously if there's any neurologic deficits, there needs to be a decompression performed, especially in the setting of an epidural abscess. Here's some of the prognostic factors indicated with a poor outcome. So these are things that we kind of mentioned is older patients, if they have involvement at the cord level, so cervical or thoracic involvement, diabetes, they present with bowel or bladder dysfunction. And if the pathogen is MRSA, these are all things that have been shown to have worse outcomes. And obviously, one of the things that was mentioned to me on my recent spine rotation was that around the cervical and thoracic spine, people are much, much less likely to go with strict medical intervention with just antibiotics in the setting of an epidural abscess, because that is at the cord level. It's a very high risk for progression and causing a very serious neurologic deficits. So like I said, and we've mentioned this a couple of times, the diagnosis is the most important part, recognizing the patients who are at risk, recognizing the clinical presentation, ordering the appropriate imaging, and then determining the microbe to treat with IV antibiotics, and then, determining who requires surgical intervention. So that's the conclusion that these authors had with this kind of treatment algorithm paper. So another review article. So we'll pass it over to Jose now. We'll move on to some level 3 evidence.
Thank you, Sir Hender. This first study we have is basically it's a retrospective cohort study, shows basically the risk factors, organisms, and neurological outcomes in management with medical or surgical in patients with spinal epidural abscess. Here, this is written by Patel in 2014 at Spine Journal at University of Washington. So the way they did this approach here is basically, as mentioned there, they did a retrospective study of all the patients who were diagnosed with epidural abscess from their surgical center, from their major hospitals here. And among they specifically stated the inclusion and exclusion criteria here. For example, for inclusions, they have to have a formal diagnosis of the condition. Patient has to be above age 18, and it's been confirmed through radiologic and even operative findings. As well as the exclusion includes those who have any post-operative or post-interventional infections, those with POTS disease, any isolated other infections outside of the abscess, as well as even other patients who have that may have thought if they have abscess but found negative on either intraoral findings or culture studies. So what they did was they just divide each group. They divide these group patients. Once they were identified, they were placed in 3 different groups. The first group was basically were managed just surgically, and the second group was basically will undergo both mostly medically and with IV antibiotics without the use of surgical management. And group 3 were those who failed medical management and thus with this indication of neurological decrease in neurological function or increase pain tolerance, pain, and then requires surgical intervention.
So that was kind of like the crossover group that failed. So they made a third group for that.
Thank you. Right. Thank you, sir. Okay. Then at the end result, the real key thing here from all this here is marked in the red here, as you can see, was that the most common risk factor were, as Sir mentioned earlier, that IV drug users, diabetes were among the most top common risk factors, those associated with spinal abscesses here. And of course, there was a little bit of issue to know which, because sometimes there were some, for example, some had some studies in the part of the study where it talks about medical management kind of succeed with scores. Like, for example, one part shows that surgery have improved with like motor scores, but in some instances that sometimes surgery kind of decrease it in other groups there. So, and there's not really much difference in terms of like timing and so forth. So it was a little difficult to really to see what their main point was. But from all that, but we can all agree on certainly the risk factors were certainly very consistent, as we have mentioned earlier. So as mentioned there, in addition to the diabetes and the IV drug use as well, other indication for failure that's shown indicators for failure of antibiotics and need for surgical intervention include diabetes mentioned. Those with high inflammatory markers, especially CRPs greater than 115, as well as leukocytosis, especially greater than 12.5, and then positive blood cultures there. So basically, these were the main find. In addition to the risk factors, these were also the top indication for any types of that requires immediate surgical intervention, as well as in addition to in the study, they also mentioned those were, as Sohum mentioned earlier, about diminished neurological function and decreased motor function and integrity of the spine, and then that draws for immediate attention requires surgery intervention.
Yeah, I think that's really well said. Basically what they showed was that the patients who failed medical management had a statistically significant higher rate of diabetes, CRP over 115, white count greater than 12.5, and positive blood culture. So, when you're evaluating a patient, Jose, like on your sub-eyes, if you see a patient in the ER that, is presenting with spinal epidural abscess, even with no neuro deficit, so no hard indication for surgery, but they have diabetes and a CRP of 120. I mean, based on this, that would be somebody with, two risk factors, 40.2% risk of failing medical management alone. So, it is something important to keep in mind that if somebody has these risk factors and they're going to fail medical management, or likely to fail medical management, do you wait until they develop a neurologic compromise? And I think that the authors address that kind of in the next set of results.
Thank you there, sir. And basically, as we mentioned earlier about the risk factor and so forth, and of course, what we see here also, especially when you look at the top left graph there, you'll see that more than half of all the in terms of the section of each of the spine there, the lumbar was predominantly was majority in all, which we can see that's usually very consistent with other studies that have shown that as well. And of course, you have down the bottom there showing which were the culture study shows which one were the predominant microbes involved, and they see was Staph aureus was the most common one. 40% were the methicillin sensitive, and of course 30% shows was MRSA, but certainly Staph aureus was truly the most dominant overall there. And of course, there were some other known pathogens there, but a lot that usually depends on what locations and risk factors, so forth there, like tuberculosis, as well as brucella, and then afterwards fungal infection. But usually they were very in the more rare cases, and usually it's location dependent based on where you are. So overall there, that as we mentioned earlier that the medical management present with higher starting motor scores than surgical patients there. Although the surgical intervention group have been taken after early diagnosis of abscess there, and then any delay, as I mentioned earlier, any delay in terms of the treatment or intervention results in lower post-operative motor scores than if you've done, let's say, early surgery. But of course, this idea is there's a lot of controversy about it, because as much as we know that many spine surgeons are very aware about these abscesses and infections and so forth in the spine there, but despite that, the clear management of it is certainly a little controversial in terms of like presentations, and should we wait for blood culture. Sometimes you need like a second, like 2 blood cultures in order to get a really true definite confirmation of the microbe or the organism in question. But either way, how you look at, one thing's for certain there, and as you see here in the last bullet there, certainly diabetes, leukocytosis greater than 12.5, positive blood cultures, and CRP, inflammatory markers greater than 115 are certainly risk factor indication for failed medical management, thus warranting for surgical intervention.
Yeah, I think that that's a great conclusion. And they may not be hard indications. Like I would be careful saying that hard indications for surgery, but definitely something to push your decision making or to think about when you're evaluating and coming up with a treatment plan. And like you mentioned, if somebody's presenting, so this is obviously retrospective study, so they noted that the patients who were treated medically only had higher Asia motor scores at baseline. So that's just showing that they were more likely to operate initially on patients with lower than nearly perfect, because the medically managed patients, their Asia motor scores were like 99 out of 100, and the surgically managed ones were closer to 80 out of 100. So obviously, like consistent with everything else, if you present with some neurologic deficit, you're going to initially be treated with surgery. But the key, I think, is that in the patients who they managed medically that then failed, they had a worse improvement than those who were initially operated on. And I think, and you mentioned that. So if somebody's going to be treated medically, but has a lot of these risk factors, which may mean they're at high risk for failing and eventually needing surgery, is it better to operate early on them? And I think that's kind of what these authors are advocating, is that if somebody's going to eventually need surgery, early is better than waiting until their motor function declines. So I think that, this is helpful in identifying patients who are at risk for failing medical management. I think that's the value of this article.
I agree. Okay, and next we have here is the a rather much the what's referred to as the Infectious Disease Society of America, or IDSA. And basically what this was about is basically a comprehensive review on a not so much on a national level, but this is more of a global level here on the true diagnosis, treatment, management of vertebral osteomyelitis by Burpee et al., published in 2015 at the Clinical Infectious Disease Advanced Access and done at the Mayo Clinic. And as I mentioned earlier about this was based on recommendation from the IDSA, or the Infectious Disease Society of America, pertaining about diagnosis and management of patients with native vertebral osteomyelitis. And basically what they did was they have a group discussion and going back to the prior literature. I mean literature that goes back decades ago, to really go through to see which were the best recommendations and approaches, and based on evidence. And they used what's called the GRADE system, which is an acronym, stands for Grading of Recommendation, Assessment, Development, and Evaluation. It's when you, as we go further, you will see just how very elaborate this whole this was, not so much to find the answer for it, but some other aspects of it that they took a while to do. And then and of course the issue was to determine the diagnosis of a vertebral osteomyelitis. Were very difficult, as we mentioned earlier. The controversy aspect to it was based on serologic, radiologic, and microbiologic testings, as well as questions pertaining to the optimal diagnostic strategies in patients with with NVO remain unanswered, as we mentioned in the we mentioned about the epidural abscess, the spinal abscess we mentioned the previous was an example of that. And then an extensive review of the pathophysiology that's not in scopes of these guidelines. And of course, as I mentioned earlier, because since this was a very large from multinational approaches, sometimes some countries have their own specific guidelines and so forth. So basically, they're trying to set up these guidelines based upon these pre-developed questions to ask. And these questions basically, as you can see here, there were 13 questions, but the primarily ones you see here is basically asking what would be the diagnosis, what would be the appropriate evaluation, should any image guiding aspiration or biopsy should be necessary, and as well as those is what's the next step in it, is imaging still needed to, what's the duration of the antibiotic therapy, and even what are the indications for surgical management. So they have gone through practically answering each of these questions in a way to do it. So how about they go about, as I said earlier, is that they went through a very extensive literature search from date back for like decades, like I think it was 30 plus years of this information to determine what would that from all the accumulation of those literature searches, they will answer these questions each individually and come up with a score, or kind of like a grade. And we'll show this later, the different grade, like what was considered to be high and weak, strong and weak, etc. So they drafted into three different groups, and divide them into diagnosis, management, follow-up, in accordance to these guidelines. And how they do it was, they did, as I mentioned, they did a literature search from various databases like PubMed, Google Scholar, Cronky, etc., as well as, in addition, textbooks and other relevant articles, websites, review articles on this subject. And then each one of them will be evaluated consistent with other IDSA guidelines, as well as also to evaluate the quality of the grade of each recommendations. That's why I was saying earlier about some of them will be strong or strong medium, and then some of those will be weak or weak strong, weak, etc. So they're bracketed in different categories. So we're going to highlight some few of these recommendations they did. Like, for example, the diagnosis among them will be include suspicious of diagnosis of new worsening back pain, fever, which we stated earlier. Clinician suspects diagnosis basically with nursing back pains, elevated inflammatory markers, as well as also suspicions of with worsening back pains and any bloodstream infections, as well as infective endocarditis. And then the next one asking about diagnosis, diagnostic evaluation. It was recommended prenatal medical and motor sensory neurologic examinations, and then obtain blood cultures. This was referred to taking two sets, one for aerobic and anaerobic, and then a baseline inflammatory markers for some suspicious of osteomyelitis. They also recommend for spinal MRI for strong suspicious of NVO. And then when they ask concern about there should be any imaging or biopsy done, they came up with they recommended that imaging guide aspiration biopsy in suspicious of NVO based on clinical laboratory and imaging studies, as well as a known microbe diagnosis. Basically, they cultured it and it was able to be identified, but has not been established by blood culture or serologic tests. Okay. And then when asked about should IV medication be withheld prior to an imaging, diagnostic, or biopsy, they came up with a conclusion saying, as a strong suggestion, that the patients with any neurologic compromise with the presence or without the presence of sepsis or any immunostasis instability were recommended for immediate surgical intervention along with empiric IV antibiotic therapy. And then when asked about what's the next step in terms of with non-diagnostic imaging aspiration biopsy, so what they did was, in absence of any kind of any presence of infections like sepsemia, to obtain a second aspiration biopsy with very high suspicious NBO with basic aspiration biopsy. In the case of any like staph infections or any kind of other probable microbes as listed here. Patients with a non-diagnostic first imaging inspiration and any requires further workup. They exclude any like say atypical kind of microbes like anaerobics, Bacilla, microbacteria, fungal, etc.
Interesting. So I think, I actually, we typically just send anaerobic and aerobic cultures. So I think, it's interesting that they're saying, in patients who get a biopsy that is non-diagnostic or doesn't grow anything, that's when then they're recommending to do these, obscure culture media and, fungal testing and stuff. I think and that makes more sense instead of sending that right off the bat when you're most likely going to grow staph. So I think that's an interesting point is when to be, looking for rare organisms. It's only until you've not grown something the first time.
Indeed, agree there, sir. It's kind of like when you think about, remember we were talking about, like, say, for example, when a patient comes in and you determine they have, let's say, infective endocarditis, we always typical like your typical bacteria, but they all alongside they tell you there could be a possibility it could be these other rare right. We call an acronym HIC bacteria. So it's kind of like the same story here. If your typical ones are not considered, they consider the rare ones.
Right. So when an empiric antimicrobial therapy should be started. So if they're stable and have no neurologic deficits, the authors recommend holding any empiric therapy and waiting till you can get culture data so you can give targeted antibiotics. And obviously, like as they mentioned, you can start empiric therapy if there's hemodynamic instability, sepsis, or progressive worsening neurologic symptoms. That is a little bit redundant. And then they've agreed optimal duration is 6 weeks, so minimal 6 weeks of IV or highly bioavailable oral antibiotics, and then indications for surgical intervention. So, these are kind of the ones we've heard also from the Vaccaro paper: progressive neurologic deficits, progressive deformity, spinal instability, persistent or recurrent sepsis, and those are their recommendations. Obviously, that can vary patient to patient, and I think generally speaking, I took this as more of guidelines for the medical management. So, biopsy, antibiotics, duration of antibiotics, not necessarily the indications for surgical intervention, which are a little bit more complicated and decided on a case by case basis. But regardless, I think that this is a good article to review. At my institution, we get consults for vertebral osteomyelitis and epidural abscess and IV drug users relatively frequently, and it's definitely a multimodal approach. The medicine team's involved in treating comorbid conditions. We've mentioned, diabetes, renal failure, cirrhosis, HIV, things like that. Those need to be addressed. ID team is obviously involved in the antibiotic selection and duration. And then, we're there if we're not able to obtain bacteria. We're also the ones doing serial neurologic exams to ensure there's no neurocompromise. And then obviously if surgery is indicated, then we will perform our role. But it's definitely something to be familiar with, and it's something that's increasing in prevalence.
Certainly agreeing there, Sir M, especially as you mentioned, this is usually a multidisciplinary team approaches. Consider the fact there's both medical and surgical side to it. It's kind of like because in a lot of these conditions, a lot of times you got to monitor a lot. It's kind of like almost like doing tumor boards kind of approach kind of things. And especially because a lot of times some of these, even with masses, let's say in thing is an abscess, but in reality it could be an oncology, could be like a tumor, for example. That's why a lot of times that sometimes these infections have to, in these presence of these masses, you have to rule out, let's say, oncological, because they could be very present in terms of symptoms.
Yeah, it's funny. In peds, we call osteomyelitis the great mimicker. So, it can look like sarcoma sometimes on imaging, but it's definitely, important to rule out everything when you're working up mass or tumor, you want to definitely rule out infection.
Agree.
Well, we included a couple of other papers at the end, and this is a little bit of a redundant topic, and these are review articles, not high level evidence, but they kind of review some of these points that I think are important, for junior residents as they start seeing these consults and thinking about working these patients up. One thing I may not have mentioned is imaging the whole spine. So there's often skip lesions, or there can be an abscess in multiple locations. So I think that in general, it's important to image the whole spine. Obviously, that can vary case by case, but if somebody's septic and seeding at one level, you just want to make sure that there's not other sources of infection as well. All righty.
We thank you this concludes our presentation. We thank you for those for watching there, and we thank also Suram and for his presentation there, and we'll look forward for the next topic round. We'll see you next time, guys.